Hello, welcome to the FTD support group webinar run through rare dementia support. My name is Professor Jonathan Rohrer. I'm a neurologist at University College London, for those of you that haven't met me, and welcome to the new people, and welcome to those returning to a meeting today who've been before. As you know, many of you will know, we have been running online meetings now since the start of the pandemic, but the plan will be to go to a hybrid system where we will start running some in-person meetings, and hopefully we'll get to meet you in person as well. And there are benefits to both of these types of meetings. We've certainly had people from much further afield whilst we've been doing these online meetings, but there is some benefit for people getting to meet in person, and some of those conversations you have during the coffee break can be incredibly helpful of sharing people's experiences and being able to ask us questions in person as well. So today we have 3 talks, all from our team internally today. So I'm very delighted to have people talk about the different stages of frontotemporal dementia, and there's enough time at the end to ask your questions. So please put those in the Q&A box, and we will get around to everything. If we don't get around to it during the actual session today, then we will be able to answer things outside of the meeting as well. But please put as many questions as you can, and we'll take questions and answers at the end. We'll get our way through the talks, and I will introduce everybody as we go. And we'll take it from there. One thing just before we start is just to remind people that we are running now some peer support groups for FTD carers, for people to meet each other. These are on the first Wednesday of the month, and if you've got involved with that, fantastic. I hope those are helpful. If you haven't and would like to be part of that peer support group, then please drop our RDS team an email, and the email is on the website, but if not, hopefully you find a way, drop a line to directly to Nikki or one of the team here today about things. So without further ado, let's get started. One of the things that we are often asked in these meetings is really about coping with behaviour in the absence of really good pharmaceutical treatments. Often dealing with behavioural change at home is very difficult, and it's often about working out the right strategies, and people often share with us strategies that they have used, that we're always learning new things. But Livy from our team will fill you in on some of the things that we've learned over the years, and things, strategies that we know can be helpful. So I'm going to hand over for the first talk about the early stages and coping with behaviour at home to Livy.
Thank you, John. Okay, so hi everyone, it's Livy from the direct support team, and I'm absolutely thrilled to be here with you live but online to chat about one of my favourite topics, which is early changes in behaviour and what strategies we can use to help. So what I'm hopefully going to be doing today is providing you with some strategies that might be useful in managing changes in behaviour. And everything which I'm going to talk about today is a non-pharmacological approach, so no medication involved, as this is the first line response to symptoms of bvFTD. Now, anybody who knows me, anybody who's previously spoken to me, knows that I really love a model called the Caused Assessment and Problem Solving Model. I think Nikki and Claire, who are speaking a little later, are putting £1 aside every time I mention it, and soon they're going to have enough to put us down a small deposit for a house. So yes, the caused assessment model. It's for helping to identify possible behavioural strategies. And I'm going to be taking you through that today because, in my opinion, it's a really lovely model to identify person-centred individual strategies which might be helpful for your loved ones. And I really do urge you all to use it to think about behaviour. So finally, before I get started, a reminder that, of course, today, all my suggestions are not an exhaustive list. And as always, not every strategy will work for every individual. And not every strategy will work every time it's applied. So it is sometimes about doing a little bit of detective work, a little bit of trial and error when thinking about these practical strategies for behaviour. And also just to mention that today I'm going to be focusing or talking a lot about bvFTD, but lots of the suggestions which I'll be giving today are applicable to other forms of dementia. Okay, so the cause model, and this is particularly useful for problem solving in dementia. But as I said, it can be used for all types of dementia, not just FTD. And this model encourages us to consider all potentially contributing factors and unmet needs. So the acronym is really simple, it's really easy to remember, and can help us think about all the confounding factors that may have caused, pardon the pun, or triggered a behaviour. So C for communication. Does your loved one understand what you're trying to achieve with them, or what is expected of them? A for activity. Is the person living with FTD overstimulated? Are they bored? Do they have enough support to enable them to complete a task? U for unwell. Now, this is sometimes something which we don't think about as often as we should. And this is particularly helpful if there's a sudden increase or an acute increase in behaviour. Is the person unwell in any way? Are they in pain? Is there anything going on like infections, UTIs, which we know exacerbate behaviour? S for story. What were your loved one's interests, their form of occupation, their personal preferences, their significant life events, their culture, attitude, because all of these things may be informing their behaviour. E for environment. For example, is there a lot of noise distractions? So for example, today I have a lot of building work going on outside of my house. Or are there any other aspects to the environment that we need to take into consideration? And then finally, D for dementia. What is this person's diagnosis and what does that mean for them? And what are their retained abilities and how is this affecting them? Okay. So we know that bvFTD is typically characterised by these early behaviour changes. A person living with bvFTD might be quite apathetic, so a decrease in physical activity, maybe less motivation, maybe some emotional blunting or less interest in things that they previously enjoyed. Equally, a person living with FTD might present as quite disinhibited. They may have difficulty regulating their behaviours. They might be restless, impulsive, and maybe do things that other people might perceive as being socially inappropriate. Or there may be some distinctive compulsive behaviours, so things like repetition, ritualised behaviours, even some muscular rigidity. So some incredibly varied symptoms there. It's also important to note at this stage that change can represent an enhancement of previous personality traits. So for example, somebody who was previously quite meticulous or quite methodical might become overly obsessional or rigid. But sometimes these changes can be a complete departure from their pre-morbid nature. Okay, so we're going to move straight into my first example here. So my husband has a diagnosis of bvFTD. I'm concerned that he has lost interest in everything, even day-to-day activities, and seems withdrawn from us. Okay, so first of all, what is apathy? Apathy is probably best described as the absence of an internal drive to accomplish a task. And a person with apathy might present as having a lack of interest in doing daily activities or personal care. They might reduce their social interaction. They may lose interest in their pastimes. or any previous routines which they enjoyed. They might have diminished spontaneous speech, so you might find that you're carrying conversation a lot more or bringing up topics of conversation a lot more than usual as a carer. There may be some indifference, some emotional blunting, and loss of motivation to do tasks. Great, so now that we can identify what apathy looks like as a symptom, let's look at some possible strategies using our CAUSED acronym. So C from our CAUSED acronym for communication. Use positive motivation and feedback. Try not to nag or harass the person living with FTD. A for activity. Try and match activities and tasks to their person's abilities to reduce the risk of frustration. And remember to capitalise on your loved one's remaining strengths to promote activity. So, for example, retained literacy skills may allow for things like word puzzles, etc., etc. U for unwell. It's important to note that a sudden or acute reduction in motivation or alertness may be a sign of an acute illness. So you may want to visit a GP for a medical review or screening if this is the case, and if apathy has come on quite suddenly or there's been a dramatic increase over a short period of time. S for story. So using the person's previous life history to help us inform with things. So previous life roles, can these identify meaningful activities and opportunities? You could use something that the person likes to help motivate them to complete activities. Now, this is really useful when thinking about those more mundane day-to-day activities like showering or bathing. For example, if a person living with FTD really enjoys and really values seeing their grandchildren, you could use this visit as a motivation or a reason for them to have a bath or a shower or wash their hair. E for environment. Establish a timetable, and you can direct the person to this timetable, a list of tasks, a list of prompts for activities throughout the day. And remember that routine will really help people living with FTD and dementia, and regular routine is your friend. And then finally, D. So please do remember that apathy is a symptom of FTD and it's not laziness. They're not the same thing. Apathy is due to the loss of our starter motor function in the brain, in the frontal lobes, and this drives our impulses and helps us initiate activity. Therefore, carers may need to start taking over these initial starter motor functions to help their loved one. Okay, so our next example is about disinhibition and impulsivity. So our example here is Mum has a diagnosis of bvFTD. Lately, she's been stealing chocolate and sweeties from shops and overspending on impulsive buys. Okay, so first of all, what exactly is disinhibition and impulsivity? Some people living with FTD can find it difficult to control their impulses, even when the behaviour may not be within social norms. Disinhibition and impulsivity can present like things such as irritability, social rule breaking, shoplifting in this case, impulsive buying, impulse eating or drinking, sometimes even sexual disinhibition, roaming, and behaviours that other people might consider immature or risk-taking behaviours. So looking at our caused assessment model, looking at C for communication, it's really important to avoid trying to rationalise with the person in this situation, as this isn't going to be helpful. Lots of people living with FTD, their ability to rationalise has been affected by the dementia. So instead, try to remain calm and don't respond with anger or frustration. A for activity. Can shopping become an activity that's enjoyed together or with a carer rather than performed independently, as this would increase supervision and external control of impulses where there might be a higher risk of shoplifting, so pinching those chocolates, pinching those sweeties, and consider whether smaller retail outlets might be more manageable and easy to supervise. I've also worked with families who have informed the shops. They've told the shops that their loved one has a diagnosis of FTD, and the shop's been able to start up like a tab for any items which have gone missing. We understand that impulse stealing can sometimes become a significant issue for carers and care workers. And if this is the case, you might want to consider alternative environments for social activity and outings which won't cue this behaviour, as well as thinking about things like debit cards, which you can top up with money if the person is spending a significant amount of money on impulse buys. And I'll come back to this in a second. U for unwell. An occupational therapist might be able to conduct an assessment of a person's safety to independently go out into the community. You can often access occupational therapists through your GP or through social services. S for story. Does the person's preferences, life story, etc., provide an alternative activity which can interrupt something like online shopping? Can you offer something that's equally interesting instead of the person online shopping to stop this? E for environment. You might want to consider reducing access to unwanted marketing, for example, adding a no junk mail sign to the letterbox or diverting mail to the post office. Where spending and buying has become an extreme problem, it might be an idea, or some carers I've worked with have put passcodes on the phones and modified web access to reduce the mediums which a person living with FTD can purchase things. Think about reducing access to large sums of money. So going back to my earlier point, you could have a card that you top up with an allowance. So for example, Monzo cards, I'm sure there are other brands available where you can top up with a certain amount of money for that person to use and spend. And if spending is an issue, really do think about reducing access to independence in environments which cue this behaviour, or shopping centres that aren't as large or busy. And finally, D for dementia. It's really important to remember that these behaviours are not within the person's full control, as the functions of the frontal lobes, which help us manage our impulses and monitor our conduct, have been disrupted by FTD. And sometimes as carers, we need to help the person maintain dignity. So providing an explanation for socially unusual conduct or behaviour and help regulate that person's safety. So you might want to do this by carrying cards with you, which explain that the person you're with, your loved one, has a diagnosis of FTD, which can be handed over discreetly. Okay, and finally, we're going to talk a little bit about compulsive behaviour. So there's example 3 here. Dad has a diagnosis of bvFTD and has started to develop some repetitive behaviour and rituals and gets upset when we ask him to stop. Does he have OCD? Okay, so compulsive behaviours and rituals is something which is really commonly seen and discussed within the direct support team. First, to clarify the difference between OCD and the behaviours seen in people living with FTD. Obsession is a constant worry or concern about something, whereas compulsion is the feeling of need to perform a task over and over again. Often people living with OCD, it tends to be driven a lot by fear or anxiety that something bad will happen if they do not follow a specific ritual or if it is not performed. Whereas people living with FTD tend to have very minimal insight into their compulsive and repetitive traits. And these traits tend to be very involuntary rather than driven by anxiety or fear. So although they may look quite similar, there is a very definite distinction between symptoms of OCD and FTD. So compulsive behaviours in FTD might look like repetitive noises, such as singing or making a specific noise again and again. They might represent inflexibility or difficulty changing thoughts or difficulty changing from routine. They might present as substance use, so things like alcohol intake. It might be repetitive movements like tapping or clapping. It could be eating a fixed type of food. It could also be repetition of tasks or routines, things like chain smoking, hand washing. It could also be things like hoarding, or it could also be sexual compulsions also. So with our example, we're going to look at the caused acronym again. So C for communication. You might want to try ask simple closed-ended questions to keep conversation flowing and interrupt repetition. Things like music and singing might interrupt repetition temporarily and might become a more acceptable outlet for repetitive noise behaviours. A for activity. Can the behaviour be redirected into something that has purpose? So can clapping be redirected into something that's more contextually appropriate, like clapping along to music? Or offering something in the visual field that cues a less destructive behaviour, if this is the case. So, for example, for somebody who might be putting things in their mouth a lot or having symptoms of hyperorality, so chewing on sleeves, etc., you might want to offer sugar-free lollipops, chewing gum, if swallowing is intact, or things like chew sticks, which can help the person with that behaviour. For someone who is picking up items belonging to other people, you might want to offer objects of interest. So things like photo albums, fiddle mats, sensory items, anything as an alternative to manipulate that won't be upsetting other people. Thinking about sensory alternatives to divert from behaviours such as massage and art can be helpful. And importantly, don't expect the person with FTD to be able to adapt to our expectations and new environmental routines. Sometimes trying to disrupt rituals can sometimes cause a decompensation in that person's mental health and mental state. So behaviours, where possible, do try and respect them if they are harmless. Try and keep to a person's routines and their preferences if these are harmless. Do think about risk. So for example, if this is eating at a particular time, going out at a certain time, going out for walks at a certain time of the day, it's very important with compulsive behaviours to pick your battles. U for unwell. So acute illness may exacerbate or intensify the symptoms of compulsive behaviours. So it's very important to rule out any reversible causes. For example, repetitive picking or scratching of the skin may be a compulsive behaviour, but equally it could be due to a medication reaction or skin condition. Repetitive vocalisation could be because of pain or discomfort or loneliness. So it's really important to rule out any reversible causes or unmet needs. S for story. Do previous life roles provide cues for redirecting into more meaningful activities at all? So somebody who previously worked in admin, for example, might enjoy paper sorting tasks. Somebody who previously was quite house proud and enjoyed cleaning may still enjoy doing repetitive household tasks such as sweeping or folding sheets. So do have a think about your loved one's history and get creative. E for environment. So is there any visual cues? For example, somebody who is clock watching or looking at doors, constantly trying doors, potentially think about where that person's sitting and what is in their immediate lines of vision. Is there anything which is going to be cueing or triggering this behaviour? For example, if a person was sitting in front of a clock or if they were sat where they could clearly see a door or door handles. And finally, D for dementia. As well as being the starter motor of the brain, the frontal lobes are also the brakes of the brain and provide feedback on how we perform and picking up information from cues on what we're doing and if it's socially normal or not. So do keep this in mind, that these behaviours are not within the person's full control. Okay, so you may have noticed that I can speak forever on this topic, but unfortunately I'm getting to the end of my allocated time. I'm going to be on the panel today, so if you do have any questions about early behaviour changes or strategies, as always, you can put a question in the Q&A box, or equally, if it's something which you'd like to chat about one-to-one, please do contact the direct support team at contact@rarementiasupport.org. And thank you so much for listening. I hope that there's some takeaway points from my talk today.
Fantastic. Thank you so much, Olivia. That's very kind of you. And as I said, we won't take questions now, but Olivia will be around on the panel later for us to take any questions related to this. I think it's really helpful to have a way of thinking about these things, and we are constantly asked these kind of questions around how to redirect and how to help with these kind of behaviours. And we know that you all have helpful things to share. And if you do, the panel doesn't need to be just about questions. It can be about things that people want to share about ways that they have also found that have been helpful with certain behaviours. And we always learn from you and from things that people have done. So let's move on, and we're going to hear now from Nikki Zimmermann. This is really thinking about the sort of next stage of things, which is when do I need help? And I think I've already seen one comment in the Q&A, which is really about thinking about stages. And I suppose there's we don't have a very good staging system for FTD, but a good way to think about that is the mild stage is when people are at home and things are not really interfering with their day-to-day function. Things move into a moderate stage when people do start to need some help. But it is a difficult question, and we get asked that question all the time. And Nikki, try and deal with some of those thoughts around when do I need help and when do I need something extra. And Nikki, I'm going to leave it with you.
Thanks, John. And as Livy stated, she was delighted to be here, and so am I. And I've got a fantastic team, the direct support team. And if we can do anything to help you on your way with this really roller coaster of a journey, then we will do. Livy's going to be helping with my slide. I'm doing a bit of a Chris Whitty today because there was a very complicated setup with the slideshow today. So Livy, if you could just press on, please. Thank you. So we're going to be talking about that million-dollar question: when will I know that I need some help? And we get asked this all the time. Is it going to be 6 months after diagnosis? Is it going to be a year? Is it going to be 2 years? And the answer really is it's very different for everyone. We really haven't got sort of timelines here. But what we want to do today is give you some sort of information to help you make that decision yourself and start putting some plans into place. Not everything I say today is going to be relevant to everyone, and I do apologise about that. I hope it's going to stimulate some questions you're going to be asking yourself and some ideas, and I hope there will be some sort of little gems that you'll be able to take away from the presentations today. So my first bit of advice is please do not wait for a crisis. These can, be really devastating for people, and putting care into place in time of crisis is always problematic. We're not in our best frame of minds. We make knee-jerk reactions. We make bad decisions, and sometimes those bad decisions can make things spiral and things get worse and worse. So please, be prepared. Take a bit of advice from either us or for your local support, whoever's involved in the care. Get some psychoeducation, do some reading, look at our resources. Knowledge is power in the end of the day, and sort of it really does help you make a decision. And although we want you to live in the moment and enjoy every day as much as possible, planning ahead and looking sort of to the future, 3 months' time, 6 months' time, what's going to happen. Have a look at what sort of options are going to be available to you. And really important as well, I think, is introducing care and support in the home slowly. So it's really subtle, so it doesn't make huge environmental changes. It doesn't upset sort of everybody's day-to-day life, but it's just some little simple things that can put into place that can really make such a difference. Thanks, Liv. So what we're going to have a look at today really is when there are impacts due to behaviour variant FTD. So we're going to look at mainly sort of the household, and we're going to look at a model sort of around the house. We're going to look at the needs assessment, which is something that's done by the local authority. Some people really are a bit scared about that, and hopefully today we're going to make that a bit of an easier process in your heads to actually accept the help of getting an assessment first of all. But we're going to look at how it affects you and your family in the home, but also outside the home in the community? Is it stopping you having any fun? Is it stopping you doing things that you normally would like to do and you enjoy doing? So we want to concentrate on these couple of areas to help you sort of process it in your head of, actually, this is identifying where I've got some needs here and perhaps I could do with some help. Thanks, Livy. So, as I said, we're going to look at identifying the needs in the home. And these categories that I've got down here are the categories that the local authority will look at when doing a needs assessment. Now, I just want to add that having a needs assessment doesn't automatically mean they are going to provide that support for you. It is literally to identify the needs that you and your loved one has, or your loved one has, that you need some help with. And then options will be given to you for what that support could be. A financial assessment will be needed to see whether you will gain any of that support free of charge, or otherwise it will just give you a list. If you don't feel you're ready to actually have that assessment with the local authority, you still sort of weighing it up in your mind and you're still thinking, do I have those needs? Do I want to still feel a bit private about it? Hopefully today you can go away, taking the information from this, and we will be sending the slides out for this next week with the link, so you can go through the slides, you can actually watch it again slower and actually have a look at the different categories and see how that has an impact on you. So what we're going to look at is the categories of food and nutrition, personal care and toileting, getting dressed, safety in the home, maintaining a habitable and clean home, and we're going to look at sort of relationships. And we're going to do this by looking at the different rooms in the house where this can have an impact. Thank you, Livy. So if we look at the home and we start off in the kitchen and dining room, is where I'm going to sort of set sort of the categories of food and nutrition. Now, Livy has just given you a really good sort of talk on shopping and disinhibition and compulsion. So we know people with FTD are going to have problems in this area. And actually, with the generic assessment that the local authority do, we really have to evidence that their needs are very different because of their disease. So when they look at the food and nutrition category, they'll look and ask the questions of, can the person with FTD plan a meal? Can they go and do their shopping? Could they prepare the food for the meal? Could they cook the food? And is there any problems eating with it? Now, if we look at those, we do know people with FTD do tend to have a sweet tooth or like some carbs. So when we're looking at planning a shopping list, it might be a bit limited to what would actually go on that. Also, as well as Livy very nicely identified, shopping could be an issue. There could be lots of chocolate in the supermarket trolley. There might be lots of food not going in the supermarket trolley and might be eaten on the way or put in pockets. So there's lots of areas here where there could be problems. With the preparing and cooking for food, there might be lots of pasta made and eaten straight away. So, not waiting for everybody else, not having that etiquette as one would normally expect, but continuing on with that food preparation, food eat straight away, and sort of ignoring everyone else, which causes some disruption in the house. So that's one of the areas where you've got to be sort of quite sort of clever and sort of really identify the needs, what you're actually happening, which is going on personally in your life. If we go on to the health and safety, sorry, Liv, if you could go back, please. Thank you. If we can go on to the health and safety here, and we look at the kitchen area and sort of aspects of safety. So turning off the hob, making sure when the water's running in the sink that it's not left unattended. These sort of two things of realizing people with FTD may have an issue with understanding the risks and not realize this being a real safety issue. With locks as well, maybe it's compulsion there, maybe it's the the obsession of going around checking the locks all the time or locking people in. We've heard of stories of that happening before. So, again, there's looking at how this is going to affect somebody specifically with FTD. And then also if we're looking at safety and health in particular, we're looking at food in the fridge. Would that person make sure the food in the fridge, without any help from you yourself, would they make sure that that food is in date and it's edible and it's not a risk to them? One thing is sort of really important with understanding the health and safety is a lot of us live sort of within a family unit. Not everybody, and I appreciate that, but a lot of people do. And it's when we're looking at those assessments of what that ability the person has if they were left on their own, and would they understand those risks? So we're going to talk about the bathroom now, a different room in the house, and we're going to look about personal care and toileting. And we know often we get inquiries from people where there's issues with showering, not wanting to shower. How do we get someone into the shower? Or sometimes they are showering all the time. They're very compulsive with it. Again, Livy spoke about continually washing their hands. It could be a real obsession. So when we are identifying the needs that we have here, it's really important to sort of reflect and take a look back of what personal care issues there are going on there. And when we're looking at toileting, we're looking at frequency, if there was any incontinence problems, massive use of toilet rolls. We've spoken to people recently that are going through oodles of this each week. And it's really important to sort of note these things, to identify these things as a need. And if we look at teeth, we look at dental issues, and that is a real need. If people have got dental issues, if they're either obsessed of brushing their teeth so much that it's causing problems and pain, or if they're not brushing their teeth and having decay there, and again, this can be pain, it can be really quite difficult for people to be able to communicate that as actual pain, and this might come out as agitation and aggression instead. So it's really important to sort of put these things as notes of looking sort of if there are triggers appearing with this. And ultimately, all of these things go to somebody's appearance and their aspect of their hygiene and their personal care themselves, and what impact is that having on somebody, and looking at how they are now to how they are before. And if there is some problems here, I think this is really identifying a need. So if we look at the bedroom then, and going on from the showering to the dressing, and is there any support that needs to be put in place, and understanding here whether somebody can wear clean clothes all the time and they're appropriately dressed. We do know obsession is a really common symptom, and sometimes simple things which can cause problems is obsessive dressing, not wearing the right clothes for the right season, being really obsessed about a certain jumper, a certain shirt. Maybe it was a present bought from somebody. Maybe it just feels nice. And, although that doesn't seem a bit of a problem, but if it's 90 degrees outside and they're clinging to their lovely jumper that they got bought at Christmas time, it is going to cause a bit of a problem. And, support in place with that. And that can be by just actually having somebody else around to help with dressing. And if we're looking at the bedroom, we're looking at sort of our relationships in the bedrooms. And we know that sexual disinhibition and problems within sort of sexual relationships can be really problematic for people. So it's really important to get some support if you are going through issues like that. And, we'd be more than happy to speak to people privately sort of on issues there. But it really is sort of looking at relationships and your responsibilities and where there's a safety issue there. So if you look at the whole of the house and maintaining a habitable home, this is really important, because with apathy setting in and lack of insight, it's very easy for people to stop doing their chores and their roles and sort of maintaining a habitable but, environmentally friendly and safe home. So if people are sort of having issues where these are being neglected, support can be put in really quite easily and quite subtly on that. So this is identifying quite a lot of the aspects of the different rooms of the home, and I hope it can sort of put some questions in your mind to think that perhaps we could do with some extra help here. Next one, please, Livy. Now, I hope and nobody is taking offence to this, but I think a lot of the stories that we hear from people, a lot of what's going on, and so especially when they're having real issues at home within the family and how their life has changed, it's completely turned upside down from the diagnosis of FTD. And people do say to me, sometimes I feel like I'm living in Alice in Wonderland. I've fallen down that hole, that rabbit hole, and I am sat at the table with the Mad Hatter and the teapots, and life is just a little bit crazy. And we know with the symptoms of FTD, there is the complete change in personality, the complete difference in the person that you married, you loved, you've been together for a long time. Maybe it's your parent and they've changed completely. And somebody who could have been really quite sort of sensible before and very low maintenance, things have changed very differently. And I think it is looking and realizing that and actually maintaining those relationships and sometimes having to embrace some of the peculiarities so there is some sort of stability within the family home. Thanks, Livy. So we're going to talk a little bit now about the impact outside the house and in the community. One of the categories that they will look at, and which is really worth sort of identifying yourself, is accessing work and volunteering. And some people with the FTD are still working. You know, there's no reason why, you know, that things have changed that dramatically that they can't work. And if people are working, there is a legal obligation for employers to make reasonable adjustments at work to enable people to work as long as they possibly can in a safe environment. And that's understanding with colleagues, understanding with abilities. Or perhaps people aren't working anymore, but they do feel they have a need, they want to contribute to society, and we all have that right to do that. And perhaps they want to do some volunteering, perhaps they want to work within a local community project. And, you know, there's lots of people with FTD have got lots of stamina and energy and are great fun to be around. And there's no reason why they shouldn't be able to do this. So it's some understanding of how we can enable this. Do we need a personal assistant to go with someone? Do they just need a buddy within this project? It's looking at what support needs to be put in place and what their needs are. And then if we look at the facilities as well, we're looking at community facilities like going to places of worship if they've always done that once a week. How can we put in some understanding? Are there any needs that person has now which can enable them to continue doing that? Going to the gym. Again, I said people with FTD often have lots of energy and, you know, can really enjoy sport, really helps with them. And, you know, they enjoy being part of that sort of team, as it were. So identifying what needs they've got to help them to continue this. Whether they can enjoy still going to cinema and theatre, and no reason why they shouldn't. Maybe they have extra needs there that they have to go to special screenings, which are dementia friendly. And there's often times that are put on for this, which will really help. And maybe sort of some of the activity centres, they need that little bit of extra support. So it's identifying what the level of need is to enable people to still do this. Thank you, Livy. So I've given you a few things to think about today, and please do have a think about your own personal situation and what the problems are at the moment, or maybe looking into the future, what things maybe will arise. If you feel that you want to get a needs assessment, and I really would encourage that, because it really does help you being there involved in your local authority, so you're on their radar. So maybe things aren't really needed at the moment, but you're there on the radar for future. Make a diary, start sort of looking at where there's triggers, where things are actually happening, so you can look back on things. But really do realise that these needs are your needs and your partner's needs or your family members' needs, and they're real needs. You know, it's not something that we just maybe tweak to help, but you've got real needs to be identified. And actually getting some support will enable you to care at home for longer. So it really does reserve some of that energy. So I've just put a couple of quotes here, and it's about the difference that a personal assistant, and this is like the easiest way to slide in nicely to getting some support in about how it would help. And the first one says, I really didn't know if it would work, but she goes out with her personal assistant happily. They go out for coffee, and now they go and do many things together that she refused to do with me. And I think one thing is really important is sometimes as the loved one, it's really, really difficult to actually get your loved one to do things with you when they're quite happily do it with somebody else. So don't feel sort of that it's just me that it's not happening with. It might be just an extra person needs to be there to help sort of stimulate that. And then the other one was, I got to the stage when I was so embarrassed going into town with my partner. He would constantly ding the bell on the bus, talk to everyone we met, wanted to buy all the cakes in the cafe. And the PA gives me some time for me so I can do things. And if I want to go with them, she's there for the distraction. So again, it's an enabling that extra pair of hands for you to get some time as you as a carer, or actually spend some more pleasurable time together. And the last slide, please, Livy. It's really important to know that we all need a tag team around us. We need various people within our lives for support. That might be family members, that might be friends, but that might be paid carers and other health professionals. So please don't feel that you need to do everything on your own. It's really important that we need that tag team. Thank you. And that's the end of my presentation, and happy to take questions afterwards.
Great. Thank you very much, Nikki. And I can see there are already some questions popping up about things like needs assessments and personal assistance. So we can go through those all afterwards. But we'll move swiftly on, because I think the idea today hopefully was that things did link along the kind of pathway of times when things are needed. And we're going to move on to really thinking more about the later stages and the needs that people have during those later stages. And we can come back to some of the questions around it later. But I'm going to hand over to another member of the direct support team, Claire, who's going to very kindly take us through the last talk. And then we'll have lots of time to go through some questions after that. Claire.
Thanks so much, John. Livy, if you could please share my slides. Amazing, thank you. So thanks so much to Livy and Nikki for already really wonderfully covering care needs and considerations in the earlier and moderate stages of FTD. As they both said, I'm really happy to be here today joining you to cover a bit more around the later stages. So just to highlight that for anybody who's joining today, who might be in the earlier stages and who maybe doesn't feel so comfortable with covering some of the content towards the later stages, that is absolutely fine. You may just want to join us again for the Q&A portion of the meeting, which should be in about 15 minutes time. And also just to highlight that in my presentation, I've included some quotes and some insights from some of our members of our later stage program. So huge thank you to these individuals for sharing those insights. Next slide, please, Libby. So we know that we might have people joining who are caring for someone in the home as well as in other contexts. For those caring in the home, it's really important to know that you might need to increase care towards the later stages. There are a few options depending on your situation and on the needs of the person with FTD. So some people move to 24-hour care, so having a live-in carer in place. Other people might look at increasing care during the nighttime, when they may have previously only had care during the day. So it's sometimes referred to as waking nights, where a paid carer stays with the person with FTD at nighttime and they're awake during this time. So this might be helpful if the person with FTD wakes up multiple times during the night and needs support when they do wake up. So this might be with things like going to the toilet, if they have any mobility issues, and also if there are any safety concerns around them being on their own at night time as well. Alternatively, you might have carers for sleeping nights where they have a bed to sleep in, but they are available just in case the person with FTD wakes up and needs additional support during the night. So this support might not be every night, but it can be really helpful to have at least a couple of nights respite, as we know that lack of sleep has a huge impact on anybody's ability to manage day-to-day needs. Something that Nikki really wonderfully already touched on, depending on your particular financial situation, as well as where you live, care for the person with FTD might be self-funded, might be paid for by the local council or by the health service. And it's really important to look into these different options that are available. No matter how the care costs are being paid, it's important that the level of care is regularly assessed as the person's needs change. And this might be because the care needs to increase because of an increase in their needs, but it might also be to assess how the people around them and how the people that are caring for them are coping with those needs as well. So it's also helpful to have a think about putting some advanced care plans in place, again, as Nikki touched on. So for instance, discussing with your GP whether the person with FTD will be transported to hospital if they become ill, or whether healthcare will be provided within the home context. If you are caring in the home, community support is vital to ensure the needs of the person with FTD are being met. So this is a lot of different people can be involved in this community support, including the GP, which is often referred to as the gatekeeper for other healthcare services, speech and language therapists to assess swallow, dietitians if there's any nutritional concern, continence advisors, district nurses, palliative care teams, and these can be hugely helpful, not just at end of life. So no matter the context in which you are caring, you need access to the appropriate support to be able to do so. Next slide, please. So while it is possible in some situations to care for someone with FTD at home into the later stages, this is not possible in every situation. Potentially because of the level of support needs the person with FTD has, potentially because of any safety concerns, and really importantly, because of the needs of other people who care for and about the person with FTD. This might be care partners. It could also be people like young children within the home. What is really important to note here is that if the level of need of the person with FTD is greater than what can be provided within the home context, their transition to a residential or nursing care is not a failure on your behalf as a carer. Many carers speak about the grief they experience during this transition and of feeling guilty, particularly if the person with FTD previously stated that they would like to remain in the home. It's important to acknowledge those feelings of loss, as it is a significant change, but also to acknowledge that you are doing the best that you can for the person with FTD by supporting them to have the appropriate level of care in place. And the availability and level of care provided in care homes may just be able to better support the person with FTD's quality of life, which is best for them and also best for those around them and who care about them as well. So in terms of finding the right care home, Something we often get asked is whether there are specialist care homes for people with FTD, and the general answer is that there aren't. There are, however, particular homes that have the resources to support somebody with FTD. Whether they have previous experience of FTD or not, what is important is that they're willing to learn about FTD, but also about the specific needs of the person with FTD, as we know that there's a lot of variation within people with FTD. We do also have resources that can help support that education for care homes as well. We also sometimes get asked about whether you should disclose behaviours that might be a bit more complex directly to the care home before the person transitions. It is important to be honest about the level of support needs the person has. Otherwise, they will likely transition somewhere without the appropriate level of care, which will then likely lead to unmet needs of the person with FTD. Something else to consider is that the person with FTD may have a particular level of need at the moment, but that will likely change over time. You may want to keep this in mind when looking for a care home, as some care homes have both residential and nursing facilities within one home. Again, this is not always possible to find with the initial transition, and it does happen that people do move between homes if their support needs cannot be met where they are currently residing. Next slide, please. So here we just have some quotes from some of the members who have attended the Later Stages program. So firstly, people do not move into a care home to die. They move into a care home to live. You're doing a brilliant job, but you can only do so much. And it wasn't our plan. We thought at some point she would need to move into a home because her behaviour was getting more challenging. We realised that this was more than we can do. I felt all right to hand over to a team. Next slide, please. So in terms of supporting the person with FTD to transition from the home into a different context, it may take some time for the person to settle into a new environment. If possible, it can be helpful to have respite periods in a care home initially to aid with this adjustment, but again, this is not always feasible. What is helpful is to work with the staff in the care home to create a person-centred care plan. And importantly, when we're talking about the care plan, as the needs and preferences of the person with FTD will change over time, the care plan needs to change over time as well. So some things to consider in terms of this care plan might include the person's routine. So Livy's already wonderfully touched on how helpful routine can be. So looking at the schedule of the person's usual activities within the home and enabling these to continue in some way in the care home context. Triggers, so looking at things that might cause the person with FTD distress, trying to minimize these triggers and how best to respond to distress if it does occur. Activities, so enabling access to activities of interest for the person with FTD. For example, if the person with FTD feels the need to walk, and that's a really important part of their routine, is there an outdoor space where they can do so safely? Or can they be supported to walk indoors, for example? With accessibility, when talking about communication, so ensuring the home understands to approach the person calmly and gently, providing them time to respond if they're able to, and also the importance of non-verbal cues to aid with that communication where needed as well. In regards to the environment, So choosing a room in a quieter area of the home, if that's possible, and if that's helpful for the person with FTD, and enabling them to have personal items with them as well to help that sense of familiarity. In regards to scheduling visits, so you may want to plan visits around better times of the day. So for example, some people have found it helpful to plan around meal times. Some carers have also noted that they feel pressure to stay for the entire allocated visiting time. So just to try and reduce that pressure, you do not have to stay for the whole period. If the person is distressed or just not having a good day, it's okay to try that again on another visit. And just the importance of increasing awareness, so making sure that other residents, staff and families are aware of the person's needs and just increasing their education around FTD as well. Next slide, please. Perfect. So we're going to go into just one specific example here, something that we often get asked about, and that is support with eating. So changing to eating behaviours can be a part of FTD, and this might include changes in food preferences, compulsive eating, so eating a lot or eating really quickly, and eating non-edible items as well. So these behaviours are really helpful to raise with care home staff to help them to support the person with FTD. And some things to consider and to discuss might be if there's problems with access to food, if the person has problems with self-limiting their eating behaviour, making sure the care home staff are aware of limiting general access to food, so kind of storing food out of sight, and also the potential of the person with FTD eating other residents' food if that's made freely available as well. Offering snacks at the kind of same time each day to help with that person's routine and with those food-based behaviours. And also having activities in place immediately after meals to encourage the person with FTD to leave the table if that is becoming a bit tricky to manage. In terms of meal times, so if needed, staggering meal times, so having the person with FTD eat before other residents or after other residents have finished, or supporting that person to eat on a separate table or in a quieter area, and having one-to-one support with staff during meal times if needed. So for example, if self-pacing is an issue, it might be helpful to have a member of staff there to support with that. Also thinking about things like portion size, reducing that, and cutting food into smaller pieces as well. Just want to highlight here the really, really important assistance that speech and language therapists can provide in regards to kind of swallowing assessments and any choking risks, and also support from dietitians if there's any nutritional concerns as well. If the person with FTD is eating objects that are not edible, there might be some considerations to discuss with the care home here as well. So for example, assessing if there's any potential medical issues that might be contributing to this. Dental assessments, if there's any grinding or damage to teeth to kind of assess where that pain might be occurring. Removing inedible objects from reach during meal times and assessing the person's room environment as well. And as Livy mentioned, providing safe chewing alternatives as well, and redirection to activities of interest. So we have two specific examples here that have been shared. So firstly, where the person with FTD was supported by the home to have his meals separately as the mealtime context was a bit too overwhelming. And another example of the person having staggered meal times where it's a bit quieter. Next slide, please. Perfect. So lastly, we're just going to briefly cover transitioning between residential or nursing homes. So we touched on facilities that do have levels of care available So someone can transition through these as their needs change. But again, that's not always possible. Some care facilities cannot provide the level of support that someone living with FTD needs. And if you first tried working with the care home to support the person with FTD, but it's really clear that the level of care is not appropriate for that person, then it may be time to look at other care facilities that can provide that level of care. Again, this is absolutely not a failure. So it may be that the level of care was appropriate when the person with FTD initially transferred into that environment, but that their needs have now increased from that point. So once that's been decided, you then need to look at other options. So getting support from your local council, social services where available. And if the person's needs have changed and they now have primarily healthcare needs, for those in England, it may then be advisable to look at their eligibility for continuing healthcare funding as well. Excuse me. So that is the end of my talk there. So I think that will be coming on to the Q&A portion now, but thank you so much for joining us.
Great, thank you so much, Claire. So if I can invite the rest of the panel to come back in, and we've got a good time to go through questions. I'm just going to move my screens around. This is the disadvantage of being on a small screen. I'm going to go and quickly work out, here we are, where all the questions are from people. And we've got loads of questions that have come in. So thank you to all three of you. It is obviously a difficult journey, and first thing to say is that our team have a huge amount of experience from the journey right from the start, before diagnosis, and helping to get a diagnosis right the way through to the end of that journey and beyond. And I think there are many groups and many things that we can help with along right the way along that way. So please do, if there aren't things that we cover today, please do just ask us about different stages of things. One of the first things was really, first question is really about having to know, how does one know when there is a different stage? And I think the first thing to say is there is no, it's not that one day you'll be at stage 1 and the next day you'll be at stage 2. It's not like that at all. Things slowly change over time in the same way that things often slowly changed before the diagnosis. And as I'd said a little bit before, the easiest way to think about it is thinking about it a little bit like we've thought about it today, which is early stages, and the mild stage being the ability to really be at home and having quite mild behavioural or language symptoms. And then really the kind of moderate stage is when one needs a little bit more help with things and assistance with activities, but is still able to be at home. And then that moving into the severe phase is when more help and more care needs are needed. And then the really advanced stage is when all help is needed. But these are very rough, and the transition between those stages, it often will take quite a long period of time. It definitely isn't a sudden one-day change over. I'm going to go through some specific things first, just in order of the talks. But so, Livy, someone asked about recommendations for Chew Sticks. Very specific question.
Okay, so Chew Sticks is a brand. There are other brands available, I'm certain. I just know that Chew Sticks has worked a lot with some members I've worked with. It's Chew and then Sticks with 2 X's. You can get them on Amazon, you can get them online. They come in different shapes, different textures, so depending if your loved one has different sensory preferences. And something which I found really helpful is often you can get things which can attach them to collars. So if your loved one is showing symptoms of hyperorality, so putting a lot of things in their mouth, it could be sleeves, it could be buttons, it could be objects, having something really close at hand that they can use and having it attached to their clothing, so it's always with them, can sometimes be really helpful, because then that can go into the mouth and be a safe alternative as opposed to chewing on buttons, anything which can be swallowed and go missing.
Great. And then perhaps directed to you, Lily, but perhaps others can help with this, which is how do you try to limit persons' access to large sums of money when they're deemed, when they're still competent? I think that comes to a lot of things. It's about all about limiting other things, like limiting food and other things when people are still competent. How do you approach that?
Absolutely. So financial supervision in early FTD is extremely important, particularly when it comes to overspending, if that's a factor. I think first, to avoid these problems, start by offering support to the person living with FTD. So things like simplifying their finances, limiting access to junk mail, especially if it's things like too good to be true offers, things like that, and monitor their activity a little more. If overspending becomes a problem, make sure that they have access to a credit card or debit card with a relatively low limit, so they can't be taking out excessive amounts of money. Have a savings account for that, but they have access to a spending card or a debit card with a restricted amount. Really think about having a trusted advisor who can keep an eye on spending, so having a lasting power of attorney involved for finances. And I think it's really important that acknowledging financial risk with FTD, if you're noticing that, to take steps to protect a loved one's finances as early as possible to help mitigate things along the way. General tips for FTD, I would be thinking things like arranging a decision-making capacity assessment to inform whether that person does have capacity to make decisions about their money and their spending. As previously said, reduce their access to unwanted marketing, which can be a bit of a trap. And in some cases, people have put caps on certain websites or certain spending platforms, like that app as an app on your phone, which can make people spend and spend and spend. I'm not sure if you guys have any other suggestions.
It was a good suggestion. It just popped up from Marjorie. Thank you very much for sharing your experience. Suggesting getting a post office travel card, put credit on, they cannot overspend. You also see what they're spending via an app. And her husband has a £100 limit per month and can't overspend that. So I think that's a good idea. It's something we've recommended to people, assuming they can accept that. So let's move on from that. And I wanted to just very quickly on sort of behavioural symptoms. Somebody has asked about they were considering writing a script or having a card on them to explain the situation. Perhaps Nikki, you can talk about the cards we have that we already give out, because they've asked whether we already do something like that.
Yeah, we have cards that we've made which states that somebody is living with bvFTD, and a little description of some of the symptoms and what they might need help with. Inside, it has a contact number as well, so it's always safe on them. It's always a really good idea, and I think it's a brilliant idea to use with the sunflower lanyard as well, which identifies that somebody has a hidden disability. We can send these out to people self-print, so they can just cut them out and fold them and put them in the lanyards to use. But I would definitely it helps with embarrassing situations. If you can preempt this by sort of showing the card, first of all, it can be really helpful. So please, anybody, do get in contact with us on our email address, and we'll happily send them out to you.
Great, yeah, and I know from people's experience over many years, it's helpful when people have some of them in their pocket to give out when there has been a difficult situation. So I think they've definitely worked, I think, in the past. So a little bit, perhaps starting with you, Nikki, but others, about needs assessments. So who does it, and is it the same in Scotland? I'm not sure I know the answer to that. Is it known by the same name? in Scotland. So who starting off, who does it? Is it the same in Scotland? And I'll move on to a couple of other things.
Okay, so it's done by the local authority. It's by a social worker who will come out. They should come out to your house. They always used to. Then COVID came along, and a lot of it was on the telephone. According to where you live, it will differ slightly for the local authority, and sometimes you can answer the first part of the questions online. They normally do a few questions online to see whether you're going to be eligible to sort of identify those needs. So I would definitely ask, if you're asking for one, for a face-to-face visit, and actually really have some good ideas up your sleeve, first of all, to evidence those, because a lot of the needs assessments are very generic. They are looking for somebody elderly, somebody frail, somebody with memory problems and huge cognition problems. They're not looking for the answers that you're going to give with your evidence of FTD. Regarding Scotland, I had a quick Google. It's called Assessment for Your Care Needs in Scotland, so very similar. And Alzheimer's Scotland is a fantastic organisation. They don't just deal with people with Alzheimer's, they deal with all forms of dementia, and they've got some really, really good dementia advisors. So if you are living in Scotland, please, get in contact with them locally, and they will be able to help you with this process. With commissioning, whether it's Alzheimer's Scotland or Alzheimer's Society in England, they are normally commissioned to help people navigate locally. It can be a real maze out there with the health and social care system. So it's good to have somebody locally who knows what's going on in their area and can help with that.
And Nikki, just a bit on the different parts of the country around how one gets a referral to start a needs assessment, because that's some places are self-referral and others through the GP, or?
With the local authority and the needs assessment, it's always self-referral. I mean, the GP can do it for you. Any of the health professionals can do it for you, but ultimately they're going to come back to you to ask you all the questions because you have all the information. So, and if it might just delay the process trying to get somebody else to do it for you. So if you can, we would like to empower you to be able to go online and be able to ask for that yourself.
Great. There's a question about whether it's the relationship between a needs assessment and a continuing care assessment and how they're related. What comes first?
Definitely the needs assessment. The needs assessment is there to identify your needs right from the very beginning, basically. Continuing healthcare is an NHS, it's based on health. There's different categories, and you have to prove that it's not just dementia, but you have a real health need here. It's for much later stages, and it's difficult to get. It's not impossible to get, but there is a really high criteria, whereas a needs assessment just identify what your needs are at that moment.
Yeah. Okay, and perhaps, Nikki, it's not so much a question, but something that we get asked a lot is just about when you've had that needs assessment, around the means testing, and just so people are clear on what they're likely to be offered and on what the outcome of a needs assessment is.
Well, the outcome of the needs assessment will identify sort of where there needs to be help, and it quite often is with respite or with getting somebody in as a personal assistant, or it can be a companion. I mean, it varies. If the local authority will pay for it, and I think it's 23,500, ladies, can you just confirm that? 23,500, yeah. If you've got more than 23,500 in the bank, they will ask you to, you'll be what they call a self-funder. So, you will have to pay for it. The local authority will normally have some preferred providers, which they will offer to you. You don't have to use them. They're normally the cheaper ones in the area for them to offer you, first of all. They may be appropriate, they may not. Lots of care agencies are out there, and they will provide these services. And they will come and they'll do their own assessments themselves of what they feel that you need, which might differ slightly to what the social worker has identified.
I think it is, yeah. So Claire, go on, because I think this is a confusing area, and I know lots of people come back to us saying, I've had the needs assessment, but I still don't really know what to do.
Yeah, absolutely. I was just going to add on to that. I think the specific number is 23,250, but that's for England specifically. So just to say, if you're joining from Scotland or elsewhere, that number is different depending on where you're joining from. So it's really important to look into that individually. And I would just say, if in doubt, it's always helpful to just go for a needs assessment, whether you feel like you're above the financial boundary or not. Because as Nikki said, even if that social services is not going to offer you financial support, they can signpost, they can link you in with the appropriate local organisations, no matter how much funds you have.
Yeah, and I think someone has asked that question, is it worth doing if you know that you're going to be a self-funder? And I think you've answered that already. And I think my experience is that it is absolutely really important, and you get a huge amount of information that you and help that you wouldn't otherwise have got, even if the outcome is that they say that you're going to have to self-fund that. Okay, so I'm trying to sort of transition through, and the people have asked some questions about that next point then of being told that you potentially need some help. How do you approach, and what does everyone think is the best approach to saying that you're going to need what someone's called a stranger coming into the house, which it is, of course, having someone, a carer, someone that you haven't had. So just that first thoughts around how you approach discussing that with someone, and then we'll talk a little bit more about carers and personal assistants and things in a bit.
So I'll go first. I think we probably have very similar answers on this, but a lot of it can be around the terminology that you're using when you're introducing that person. So rather than saying this is a carer who's coming into this context, people find it really helpful to introduce that person as a friend or as a companion, and sometimes to introduce that person for a very specific purpose. So for example, if the person with FTD has particular activities that they enjoy doing and that they're really focused on, introducing someone in that context where they can support that person with that specific activity, rather than kind of generally introducing someone as a care provider. I don't know if Nikki or Livy, you have something to add to that.
Go on, Livy.
I was going to just add about the importance of having This Is Me documents for when you're getting paid carers to come in. So This Is Me document, which is from Alzheimer's Society, is a brilliant document which helps identify that person's story, their preferences, their life experiences. And this can be so helpful for somebody new coming into a household to know, and so that they can create that relationship, understand that person a lot quicker than they would without the document. So yeah, I would entirely recommend having an up-to-date This Is Me document.
Right. So someone's asked a quick question: what's the best way of finding out about personal assistance? Nikki, we've often thought about this. There are various places.
Yeah, there's a huge amount of care agencies in all the areas. I would ask for recommendations from people. We're quite happy to speak to anybody, but also to look on, the website to see what their ratings are as well, see what they offer. They'll normally have sort of testimonials from people, but they'll be able to tell you what they can deal with. And it's normally quite good to have an organisation, a care agency that does companionship right up into live-in care and end-of-life care. The last thing you want to do is introduce people to a companion carer when somebody's in need of personal care, and they're at that situation. So it is recommendations, but locally, and what they will provide for you.
Yeah, and I think one of the questions is a little bit about the kind of things that we can do, and a bit about I think you guys have talked about how we can help, but in terms of that next stage, about recommendations for care homes that have some knowledge about particularly young onset and FTD.
Claire, do you want to answer that as your area?
Sure. So we have a kind of list of care homes that people have let us know are helpful in supporting people with FTD. General things to look for when you're looking for a care home is the Care Quality Commission, their ratings of care homes. And there are a few different websites that you can use to filter in terms of what the care home specialises in as well. So if you do want more support with that, please get in touch with us, but we can also send the links to some of those websites as a
And Nikki, someone has, I'm sorry, Claire, someone has specifically said that apparently young onset is not a search option when you look it through the website. Is that, do you know if that's the case?
Under 65.
Under 65 is usually one of the categories that you can search.
So it's down as under 65 you have to search for. Okay, that's how that is helpful. Okay, let's quickly bounce through a couple of questions in the last couple of minutes. So a good question, which is, and we often talk about this, that sometimes a crisis occurs and you need to have some change. How do we define a crisis? I suppose that's a tough question. Who'd like to take that?
I'm happy when you're not coping, when you really, you know, you cannot see the tree from the woods, basically. You're thinking, I just cannot do this anymore. You know, I'm exhausted. And there's not exhausted that a good night's sleep is going to help me. Even if I could get a good night's sleep, it's when you, we don't want you to get to a crisis. We want to minimize that as much as possible, because that's when decisions are often taken out of your hands and it's a real risk, really.
Yeah. A little question about when there are tensions in the family, when one family member thinks that things are better or worse than the other and little disagreements over power of attorney. How would you approach dealing with those?
Livy, do you want to go for that, please?
Families are really complicated and every family is difficult. I think to answer this well, I would want to know a bit more information about the family and about what's going on, because I don't want to be giving information that's not relevant. But it is really complicated, those networks. Yeah, I would encourage that person to contact us for a one-to-one chat.
Great. So I really want to thank all the people who've been putting messages in the Q&A, and thank you to Marjorie, I'm going to read a couple of things just which have been really helpful, and it sounds like you've been through a lot of this and sorted it out. You know, one thing is the importance of finding a good match for the person coming in, and she's had some bad carers and some good ones. Important to be confident to speak out on behalf of the person with FTD if they or you are not happy, and she now has a wonderful team, but it took a while. I think that's an experience that many people will share, and I think that is important, not to feel that the first people that come in are going to be the definitive answer if you don't like the situation, and that's really I think that is really important. And Marcia mentions doing things like supplying her own listing of her husband's particular routines and practices. Again, that's helpful. You have to be the advocate for the person with FTD, and that's really important. So I am going to stop there because we've come to half past. And a little couple of things, just we have lots and lots of resources. It says, do you have any resources for teenage children? There are some good resources both on our website, but also some on the American AFTD website. Particularly, they have some quite detailed, they have actually a website, specific website for children and for teenagers, and there are different sort of age parts to that website which are very good. It's a little bit American focused, but nonetheless it's quite good from a perspective of children. So I would recommend that. Thank you to all of you that have attended. If I haven't managed to get through to your question, as I've said, we're always happy to answer them. We'll have a look through them and we can always reply to people. Personally, if you feel that you need a one-to-one call with the team, particularly just talking about the lady with difficulties with some family agreeing and not, please be in contact with us. We're happy to do that. Remember the peer support group meetings on Thursdays. I did write it down. Thursdays. Wednesdays. I've forgotten it already. I've forgotten it in an hour and a half on Wednesdays. If you want to do that, please be in contact with the team to do that. Hopefully, we will get to meet you in person, and later in the year, hopefully we'll end up being able to go back to some in-person meetings, but we will carry on these. We recognize that lots of you do like these virtual meetings, and it gives you the opportunity to come without necessarily taking some time out of your day. So we'll definitely carry on these well beyond the COVID pandemic. So thank you again for all of you attending. Thank you particularly to our direct support team, Nikki and Claire and Livy, and to the rest of the team that have helped organise things today, Alicia and Millie and everyone else. Have a good rest of your day. Please be in contact if you need any help with things.
Hello, my name is Eva Tate and I'm the Major Appeals Manager and Manager of the Rare Dementia Support Fund held by the charity The National Brain Appeal. The National Brain Appeal raises money as the dedicated charity for the National Hospital for Neurology and Neurosurgery and UCL Queen's Square Institute of Neurology. The National Brain Appeal raises funds for Rare Dementia supports 2,000 members to help individuals living with rare and early onset forms of dementia, their families, friends, and healthcare professionals. And we also hold several other funds for FTD and dementia research. The funding helps not only the support group meetings in London, but also the regional support groups, admin and support staff, and all other associated expenses, including the new online support groups. When things return to normal, there are travel and accommodation bursaries available to help members attend the meetings. This year, we've raised our fundraising target to 300,000, and this will rise further to 350,000 by 2022 to develop and extend the service in the areas of education, support, and research, with the ultimate aim that everyone affected by a form of rare dementia will have access to specialist information and support, as well as contact with other people with a similar condition. We apply for grants from grant-making trusts, foundations and livery companies, and have a wonderful group of supporters, some of whom are here today, who fundraise for us in an amazing variety of ways. We would love it if you would like to sign up to our RDS fundraising newsletter to hear more of these stories and receive news of how we can support this community. We have had people do head shaves for us. We have had a gentleman drive across the Mongolian steppe in a VW Polo, and we have lots of people who take part in runs and virtual runs as well. At the end of February, we held a gala dinner called Mission Possible, where we raised 110,000 for the expansion of rare dementia support. And we are delighted to announce that in line with this expansion, the charity is committed to raise up to 7 million to create the world's first centre of excellence for rare dementias. If anyone would like to discuss any fundraising ideas or the new capital appeal, please do feel free to email me or my colleague Alexis, our Senior Fundraising Manager, who will speak about the innovative new ways you can be involved in fundraising for RDS, even during this challenging time. Thank you very much.
Hello, my name is Alexis Gebby and I'm the Senior Fundraising Officer at the National Brain Appeal. I just want to start off by saying a huge thank you to all of you who already fundraise for RDS. We really appreciate all of your incredible efforts, especially at this difficult time. My role at the National Brain Appeal is to look after all the amazing people taking on various fundraising activities for us. We have had people challenging themselves to run marathons, cycle long distances, climb mountains, and even take on skydives, all whilst raising money for RDS. We also have wonderful fundraisers out in the community who organise golf days, hold coffee mornings, host choir and carol concerts, and even shave their heads. These people ensure that more people like you can be supported through rare dementia support. If you're interested in becoming one of our fundraising heroes, then please do contact me. I am here to support you with your fundraising, and I'm more than happy to chat about any ideas that you may have. While at the moment it isn't possible to take part in a sporting challenge or hold a big fundraising gathering in your local community, we do have some fundraising ideas, such as taking on a solo virtual run or walk, hosting a quiz for your friends or family online, asking for birthday donations in lieu of going out, or even donating money that you may be saving by not travelling to work or buying your daily coffee. Do get in touch with me if you would like to get involved. In the meantime, take care and we hope to see you soon.